We've been on this call 56 minutes. There have been 230 people diagnosed with cancer since we started the webinar, right? So if that doesn't create that burning platform for change to say, I refuse to have more than half of my patients with lung cancer be diagnosed in stage 4. I'm going to do everything in my power to get lung cancer screening to the levels that we have breast and colon. The mission should be driving these discussions, not the pharmacoeconomics, not the social economics. I just think it's critical that we start to light that fire and say again and again that we refuse to accept the other alternative, which is to not improve, not embrace, not innovate.
This is, I think, the task ahead of us. 5 years ago, I thought the hard task was figuring out which tools to use, but that is not the hard work. The hard work is implementing and change. It's going to make or break us. We are going to see organizations fail in the next 5 years. The future is changing. We have to evolve or we will die.
Welcome to AI in Healthcare, where we discuss all things relevant that are both AI and tech as they relate to oncology and the oncology practice, and even your personal life as a professional. I'm your host, Dr. Sanjay Juneja. I'm a hematologist medical oncologist, and I am joined with my co-host, Debra Patt and Doug Flora, and we are bringing you this episode from Tensor Black, along with our very good friend and recurrent guest, Mika Newton, who you all know well. We're going to have kind of a roundtable talk on everything that relates to AI and how it's going to affect our immediate future and probably the long term. So with all of that said, welcome, and we're excited you're here.
Great to be here, Sanjay.
Delighted to be here.
We have so much to talk about this time. I think one of the first things I'm going to bring up is health conference. And what are y'all excited about at Health? And what does Mark Cuban, Debra, bring to discussing healthcare and this transparency concept? I think it's actually been quite impactful.
Yeah, it is really impactful. He's really contributed to disrupting the conversation in a really positive way. I think that, many Americans really understand that healthcare is expensive and navigating their prescription drug coverage can be quite complicated. I think his model in Cost Plus of being transparent about acquisition of low-cost drugs is really been meaningful to some patients as they seek to have alternatives other than sort of managing this through their traditional insurance. And oftentimes, patients can have barriers to getting the care that they need, barriers between doctors and patients, barriers between patients and their medicines, really introduced from insurance companies and pharmacy benefit managers. It's opaque. It's a big wall. And so I think Mark Cuban's Cost Plus model really is an alternative to try to offer some transparency to patients to make it easier for them to get what they need. While that's exciting, I will say, in the space that we live in cancer care, it really has minimal impact. And that's a really complicated ecosystem. But I think that what he's trying to do to really disrupt the pharmacy agency and really help patients, empower patients with transparency is meaningful to improve the patient journey.
I think, Debra, when I think about someone like, Mark Cuban coming in here, I always think about like, what would healthcare look like if we kind of threw out the way we got here today and started fresh? So like if we had someone come at this, right, from the pure kind of entrepreneurial perspective and we had to start again, what would that look like? Not that we can do that, but I think that when I look forward to this discussion, I'm like, well, what could it be? Because always out of those discussions, I'll find like some little insight where I'm like, hey, you know what? I know we can't do exactly that, but there might be like a thread of truth that we can pull there. And I think people like Mark Cuban always bring that kind of perspective.
And I think that we're observing there are many novel disruptors in healthcare today. And I will just say I had the experience this last week. I needed a medication and I emailed my doctor. She called in my medication and it was delivered on my doorstep that afternoon. I just paid out of pocket. I didn't do it with the insurance company through Amazon's delivery service. So there are many disruptors, I think, that are trying to disrupt healthcare. And while none of them have really taken off in the mainstream yet, I think that there's a lot of opportunity for disruption in healthcare as we see the ecosystem changing. And another one is Dr. Oz, right? So for the first time, we have a leader of CMS that is really focused on prevention and doing what you can do up front from a lifestyle perspective to prevent chronic disease. And I will say, I do think that focus is really important and timely today in healthcare, where we do face a lot of chronic conditions that could be prevented from some of the behaviors that we have early in life, which is not to say that modern medical therapy is not necessary. It absolutely is. But there is more to be done in that space.
Yep. Your point about CMS is really interesting. One of the stated goals for CMS is to have all Medicare eligible Americans in value-based care programs. So those are risk-sharing agreements by 2030. And so that's 80 million people at that point in time. And so if you think about the kind of collective investment we're making then in prevention, which is the only way that anybody can really make any money out of those value-based care systems. And there's some risk adjustment that needs to be happening. Then there's, chasing down HEDIS measures and the quality-based measures where you have to do all of those things or else we will fail. I think that someone like Dr. Oz has got quite a challenge, right, of kind of combining not only getting everyone in those programs, but having everyone understand what that really means for all of us in terms of what we're going to have to do to make it work.
Hey, Sanjay, I listened to your last fantastic podcast with Bertalan. That's good. If you guys haven't heard this, it's just great. He's the futurist all over social media. But I love the term that he talked about, zooming out.
Yes.
You and I talked about that offline. And for those of you who haven't heard, he basically talks about how you start with these problems and then you back up and you get better perspectives. And I think the conversations around Mark Cuban, the conversation around pharmacy benefit management, whether that is an add or subtract, I think we all know where we would probably fall on that is treating providers. Everybody understands the system is broken, that there are going to be a ton of digital healthcare solutions offered. And as we zoom back in, those give you the tools. I'm more worried about the change management than I am the tools. I think the tools are coming anyway. I think it's going to be people like you guys on this call and our listeners that will be the leaders in their institutions who are starting to lead that charge to say the tools work for the most part. By the time you buy them, you've vetted them, you've done a good business plan, you're all set as a business leader or as a healthcare leader. I'm more worried about when everybody hears everything that's presented at Health this year. How do we get the stuff done? Because I have a team of people panicked down the hall who I bring these things to them, and they're just not quite ready yet. So I don't know where people are going to catch up on learning this. I have some ideas. I bet you do too.
I mean, that brings up a great example of something else I wanted to discuss. And it happened on October 1st. And that's that Medicare will no longer cover many telehealth visits, right? So you have a tool. Telehealth can get you access and visits, to extended areas. They can get you in certain specialties that are challenging. And there's some workarounds that's in, going to be still in place to be able to meet those needs. But it's gone, or at least I think it was supposed to be renewed in October 1st. And because of the shutdown and all, technically that time has expired. I'd love to know y'all's thoughts. One, if it's really affected you yet. And two, kind of what does that mean about tools and tools that do, arguably have benefit in an otherwise kind of strained, area?
The telemedicine piece is difficult, Sanjay, because the telehealth extensions expired with the government shutdown. Some patients have not had access to telemedicine, and that has decreased their access to good healthcare, and that's a real challenge. I do believe that the government is likely to start up again, hopefully sometime soon. When that happens, it's likely that the telehealth extensions will be renewed and even retroactive. And so I think for people that are continuing to do that, the risk is low of continuing to offer those services, but it's uncertain. And the uncertainty poses vulnerabilities. Because if you're a healthcare organization and you're saying, should I invest in telemedicine or not, as a way to provide access to patients, the fact that your revenue cycle, the payment for those services, has been vulnerable and has vulnerabilities in the future, poses risk to you continuing to invest in those services. And so I think it's a real risk. I am aware of healthcare organizations that have canceled patients' telemedicine visits and of patients that have canceled their visits. and of commercial payers that have followed suit, saying Medicare is no longer covering it. We are also no longer covering it. So that poses vulnerabilities for patients to have access. I think about as a community oncologist, right? I want patients to have access to cutting edge care close to home. I want them to not have their disease impact their life, and I want their disease treatment not to impact their livelihood. That means if you're living in rural Texas, you get to stay on your farm and you get to visit with Dr. Pat by telemedicine to make sure that your medicine dose is okay and that you're tolerating it okay. So that service really is tremendous for really supporting the goals of healthcare, to have it not hurt people and to have them support them in their livelihood. So it's a real challenge. I do think it's a temporary challenge that will have permanent, lasting effects.
I hope it's temporary. I think this is something that needs to exist. It doesn't replace regular healthcare. It's just completely adjacent to it. And I think, Debra, what you pointed out, the patient who's at home who really can't afford to or doesn't have the wherewithal to get to healthcare, this may be their only option. And I felt like we were moving forward in this space. So I hope we at least go back to where it is. I really hope you're right.
We
And
know
I
it
think
works.
just if I can just anchor us to Doug's statement about change management, the disruptions in telemedicine payment limit our ability to implement a digital healthcare tool to solve patient problems of access. That theme we will see recurrently, I think, as we have public policy influence our access to digital healthcare tools recurrently because of this change management issue, whether it's around consent for use of AI or how we're using different tools in the clinic or managing adoption. This change management piece is really critical, and how public policy influences that in our clinics and our practices really will have meaningful and lasting impacts on the patients we serve.
I think there's some good signs here. You talk about digital health. The current administration, from what I can interpret, really wants to see a digital health environment and an AI-powered digital health environment. We can talk about all the things that means. I see a lot of it coming out in my own work around communications related to interoperability systems, right? Patients' right of access. I think we've covered in other topics before, and demanding that patients have right. Well, that doesn't make any sense to have right of access to my healthcare data if I can't get a digital app that then doesn't get, help me with actually pursuing my healthcare ambition. Like, it just doesn't make sense. And so I do think you're right in the sense that the direction's clear, but still, this is an interruption, and uncertainty kills businesses. I think that's what I worry about. A good number of actually our customers are telehealth providers. So in providing data services to people, right? Telehealth is a really obvious place to provide, EMR aggregation and synthesis and all the stuff that we do. And uncertainty means contracts don't get signed, means people wait around and say, well, maybe we're going to do this or not, or they don't even get out of the gates. And so I think the sooner we can get to knowing what will happen, the better. Of course, it applies.
That's the cost to me right there, is that this volatility that we're seeing, the divisiveness of the way that things are being interpreted politically on both sides, has impeded our progress because we're gun shy now. So in my system, I'm just outside of Cincinnati, Ohio, guys, and we have 5 cancer centers, and it's about a 13,000 employee hospital system. And we have just had equipoise about making any big bets. We pushed back our strategic planning by about 6 months. We never do that because we didn't feel that we had enough corpus of information about the direction things were heading to make major investments in anything, Debra, like telehealth or other, our research enterprise or other things. If you don't know where the reimbursement's going to fall, and you know that margins are razor thin on the best day in clinical medicine right now, how do you build a new building? How do you hire 40 new employees and expand to another office for Texas Oncology? And so I guess what I'm hoping for when we talk about him, Sanjay, to go back to your original question, or AVBCC, or the co-op conferences, or the Association of Community Cancer Centers that we are all involved in, I look to those groups to try and help us forecast a little bit so we can make those bets. I listen to a ton of podcasts like this because that's where I get my information now. As I trust you guys. I know Debra knows what's going on because, like me, you're out there advocating for things. Sanjay, you're on the road about every weekend, hearing 3 or 4 smart people talk somewhere. And so I'm grateful that these tools exist because we didn't used to learn this way. It's very, very timely. No, I mean,
Very well said. And that is concerning, with how you just almost have to pause innovation just because you don't know where the limited resources might be. And just for some statistics, when you look at people on traditional Medicare, which is about 33 million older adults, nearly half of them have used digital or telehealth options since the post-COVID era, 6 million continuing to do so into 2024. I do want to say, when it comes to at least the behavioral and mental health services that are through telehealth, that was kind of made into permanency. So that's not affected, which is very important because we know the kind of, islands that exist with that. So to that same point, and also having this kind of guidance, and I know actually all of you could speak on this quite extensively. The Joint Commission and the Coalition for Health AI released an initial guidance to support responsible AI adoption across the U.S. health systems. So this is exactly going into what you were just talking about, Doug, on how this guidance is necessary. And what do y'all make of this kind of, strategic collaboration? And is it the right move?
Yeah, I think that this is likely going to anchor policy. So what we see when these kinds of joint statements come out is they're usually a signal for policy formulation. And we're in a bit of a pickle today, Sanjay, because what's evolving is the tech is there, but how we manage it in healthcare is still quite variable. And it's leaving organizations like ours trying to solve for, how do I manage these particular issues around what patients have, having access to their data? How do I manage things like consent for use of AI, consent for use of text messaging? So we don't just bring tools to patients like we would outside of the healthcare ecosystem because of the complexity of protection of PHI. Not to trivialize that, it's really important. But what's evolving, because the tech is really quickly evolving, is the policy is a little far behind. And where you have federal policy emerging with the best of intentions, you also have state policy emerging, and it can be quite variable between states, yet your solutions cross state lines. And so we're in a bit of a pickle, I think, sometimes with the policy not yet keeping up with the tech, creating challenges of implementation. We all know that healthcare is not going to be the first to innovate. We're definitely not the pioneers, not even the settlers. We're like second or third generation into when we choose to evolve. And then we have discordance in the policy sometimes from the federal and state level that poses challenges for any kind of implementation. So I love that the Joint Commission worked with CHI to develop a set of principles to kind of signal, hey, this is where policy needs to go. And I think that we know that there are leaders in government that would like to see parsimony in federal legislation to really have jurisdiction over a lot of this. But that's not where we are right now. That's where we want to be. So we need groups like the Joint Commission and CHI to aggregate to really signal where we're going. So I'm excited by it. I think it's really important.
I think if we get fragmentation, like we're starting to see, state policy is different than federal policy, et cetera. It's, again, just the uncertainty that it creates. And can I get this solution to market? How do I control where it's deployed? Can I actually implement this at scale? And it's really that scale issue, I think, that ends up keep coming back to me. For any of the things that we're doing around innovation to truly work, it has to work at scale. And that means not just in one system, it means in many systems across many states, right? At sufficient volume that the cost to deliver the services is low enough that it can actually address it. We don't have room to add more cost to healthcare. So that means when we deploy this technology, it actually has to reduce costs. So that's the first thing I tell people. You got to make more money, revenue's got to go up, or costs got to go down, and ideally both, right? Otherwise, nobody will buy it. And to do anything like that, you have to achieve scale. There's no such thing as a pilot project that actually moved the needle in any, I've never seen one that actually moved the needle in any direction or another. And when there's this kind of regulatory discord, it's just hard to get scale because you're kind of making little islands out of every single geography.
I think we may see something there. And I'll go back. And Sanjay, you are unfortunately too young to remember this, but Debra and I went through this as there was the introduction of the electronic medical record, probably 2008, 9, 10. The federal government incented us to purchase these things. And it was not a discount, but it was basically a reimbursement for investments made by private practices for, I think, was it 4 years, 5 years, Deborah, as we built up. But then at 5 year, there was a cliff. And if you hadn't installed it, now you were paying penalties. You were not able to enjoy the fruits of your labors, as it were. And I have heard rumors that we're going to see something like that coming out of Washington soon, to say we understand that the advent of AI technologies is a thing. We know it costs you guys things. We can't demonstrate ROI yet, but we so believe in the power of these tools that we're going to help you guys invest. And I'd love to see that. A lot of private practices don't have the resources to do that right now. I'm in a community setting. I can tell you we are stretched as thinly as we could be. So I would love to see a little bit of directive about that, not just the sticks, but maybe a few carrots to say, this will be worth it. Let us help you make the leap.
I think that is how you lead people along, Doug. I think you start with the carrots, you get incentives aligned, and then for people that are still not adopting, you then have the sticks that are present. And I think that, the principles from the Joint Commission and Chai's report are really similar from what we've seen evolve from other medical bodies. So I've had the privilege of chairing ASCO's AI task force, and we published some principles really to guide and direct responsible use of AI, and they were really similar. So if you look at what the Joint Commission and Chai released, it was that around AI policies and governance structures, to establish a formal governance structure that's risk-based, to develop policies and procedures for review and implementation, to develop ethical standards, to have patient privacy and transparency, which is always necessary in healthcare, some language around data security and data use protections, quality monitoring, voluntary blinded reporting of AI and safety-related events, the problems that we know can already exist, right, around risks and bias assessment, which we know we can't entirely take away, but to categorize them, to understand them, evaluate and address them, and then education and training to make sure that people are using them appropriately. So this isn't new and novel, but I think by these two important bodies coalescing around guidance, it allows really for the formulation of responsible policy.
So I've got a totally tangential story going back to what Doug was talking about that kind of emerged over the weekend, starting from late last week into this space, but it's about the carrots and sticks. So Doug, you were talking about meaningful use right around EMR records, and that became now the kind of MIPS program, which is penalizing people for not participating in other things. And sitting underneath all of this, right, is what's the certified EHR program. So if you think about electronic health records, they're either certified by the ONC or not, and that's what drive all of these regulations. Well, in an adjacent space, which is the dental space, there's a very few number of EMRs, and they're just not as up to date as medical EMRs, but dentists are physicians, doctors, right, and do some pretty complicated stuff for all of us. We think we all go to the dentist on a pretty regular basis, and there's a lot of things that can happen there. One of the payer groups that does revenue cycle management, so financial management, sued one of the dental EMRs over information blocking, essentially not allowing data out of the EHR to transfer over to them. And that is because the ONC has said in the last few months that they are going to enforce information blocking. So people who don't allow the transmission of authorized information between these different systems are going to be enforced to do penalties. The day after that lawsuit was filed, the dental EMR company withdrew their application for certification. So this is the stick going in the wrong way. They basically said, fine, you want to come after us? We're just not going to comply. We don't see any big benefit to the carrots, and we're just going to pack up our toys and go home. And so it leads to this kind of fragmentation concept in my mind, which is it's great. We have kind of like the big systems, right, and large institutions and general policy. But I think we often forget that healthcare is actually very diffuse. There's all these like edge case players, right? I think telehealth often falls into some aspects of that concept and all the rest of it. And we really need a unified, cohesive architecture. And I think healthcare just suffers from this. We just are not great at coming up with like a one size fits all that's not so restrictive that nobody wants it, right? Or that's not too permissive that it causes harm. And I still think we all struggle with that all the time.
I'll say, Mika, to your previous point, so the carrot analogy is a good one, but even to your point about the viability of scale, one thing that I think was kind of quietly changed and didn't really drum up enough, I guess, not even necessarily interest, but almost concern, is that Google recently has limited the number of searches that come up with a search. And that may not sound crazy to you, right? Like, I think initially it's always been 100. Now they've reduced it to something like 10 or 10 to 20. So when you're thinking about all these kind of innovative, startups or AI models that are trying to learn, it is like really tanked the ability for newer models or large language models to be trained, because you're not getting the same amount of search results that you normally would have. But it's even going to affect online publishers and where they get their financing. And of course, like the whole SEO concept and how much that's both a budget, but also a means of getting your ideal consumer. So just one decision like that, we all saw what happened with the Reddit stock. It just kind of really crashed when all of a sudden it's being used less so by a lot of these leading models for I don't want to call them chatbots, but for the ones that people are using commonly. So that's just one example of how one thing can really just shake up tectonically the things that are trying to either survive or otherwise potentially even very productive and positive for a certain setting.
Financial incentives work, and it's a hazard in us doing the right thing in healthcare. And unfortunately, as Doug already mentioned, we are late adopters, right? We're late adopters here. It is hard to advocate for investments in these spaces, but they can be so transformative for the patient journey. And, again, within boundaries, right? We want AI systems to breed efficiencies. We want them to give us a greater reach, to give access. We want them for things like clinical decision support to make us smarter. I mean, Sanjay, over at Tempest, the work that you guys are doing with chart summarization in a temporal nature to identify clinical trial eligibility, therapeutic opportunity is just really exciting. That work, using the best of AI. But for companies to adopt this, for healthcare organizations to use it, in the absence of clear policy, there is financial risk and unclear benefit.
Well, to that exact point, I'll tell you who is using it, and that's Medicare. Medicare actually starting in January is something. I'm a pun guy. They call it WISER model, which is their new wasteful and inappropriate service reduction model. And the design of this is really to use AI to handle prior authorizations. Now, it's not going to lead to ultimately to the final decision, which is going to be in the hands of an employee. So as that's what they say. But on top of that, one, Medicare does generally have less prior authorizations required than Medicare Advantage, but they have even some areas of focus, this WISER model, that they want to kind of relay it to assist with these prior authorizations, including skin and tissue substitutes, electrical nerve stimulator implants, and knee arthroscopies for knee osteoarthritis. So I'm just curious, what do y'all think that this will mean for the culture of not only, getting coverage or getting reimbursed for procedures you do, but do you think that procedures or certain, elements of delivering care may fizzle out or end up being less so leveraged, because of the tools that will be making the decisions on their candidacy or not?
I speak in historical context a lot with you guys. I really find when things get unsettled for me, I go back to things that I've studied that happened before. And this doesn't frighten me. I hate fighting with prior auth for insurance companies. I'm a doctor, right? That is ubiquitous amongst us. You guys, it's 100% penetrance of that gene. But I recognize that it actually serves a purpose, and that there are a lot of things that are done out of habit or because my mentor did it, that I chose to do it. And so I would point you guys towards the Choosing Wisely campaigns. Remember those? They were a big thing. Quit transfusing people for a number, right? Right? We look at that now like, of course, but in our day coming up, you had a patient drop below 9, you started shots, you gave them blood transfusions, and there were dozens of things that came out of good committees of people that were trying to do the right thing to say, listen, let's not start with MRI for back pain. That's not a good choice. And so I hope that as we see this next permutation, using the data that Mika lives in and the rest of us live proximal to, can we use better data to make better decisions, to identify when we are choosing wisely And maybe I'll punt that to Debra, because I think you guys are well ahead at Texas Oncology in starting to flirt with clinical decision support. And I know we're in the first inning of that game, and we'll probably talk about in this podcast for the next 2 or 3 years before that's done and dusted. But maybe talk about the early goings, because you guys probably took some bruising earlier, but you're about 2 years ahead of the rest of us that are trying to keep up.
Well, I mean, first on the prior auth piece, I will say it's hard not to have heartburn about it, not because of where they're starting, because I think the wiser work in low utility services is an easy place to start. But it's like you have decided it's appropriate to use a modality, and then the slippery slope to stretch that to other services that are necessary that could have barriers is really easy to cross. It's really easy to go down that slippery slope. So I think that's the challenge. The Wiser campaign is and using AI in that system of prior auth, I think is not the difficulty. It's like, where does it go from there? And people having a lot of concerns about that already. As oncologists, we know that prior authorization is a barrier to some patients getting the care that they need. But utilization management is important. Listen, I won't say that there's no role for it. I mean, there is a role for utilization management. We do need to make sure things are appropriate for patients. But I think that there will need to be some definitions around those barriers. Just like, to Doug's point, there needs to be barriers around how we think about how AI supports clinical decision making. And in my mind, that boundary is a nudge, right? I want for AI and for clinical tools to give me greater reach and to make me smarter and give me information to nudge my choices, but never to make decisions for me, And so there's this wonderful book that I think is so critical to how we think about digital tools in healthcare called Nudge by Richard Thaler and Cass Sunstein. I've bought this book for so many people. And it's all about choice architecture, right? And having AI at our fingertips is all about choice architecture, trying to get the right tools to the right person at the right time. After I read the book, just to give you an idea, I had small children at the time, and I immediately rearranged my refrigerator to put all the healthy choices of like the pretty fruits right at their eye level, to hopefully they would preference eating those pretty fruits right at the eye level, because it was easier than the unhealthier things that were a further reach. And so you want to put things right at your fingertips. So to give you a clinical example, I'll say in clinic, as a breast cancer specialist at Texas Oncology, so I can walk into a room and tell someone how to treat their breast cancer pretty easily, usually within less than a minute. That's the easy part, right? The hard part is all of the other questions. And people do have a lot of questions about other things. So an example, a patient asked me this last week, about 2 weeks ago, is ketamine, they have major depression, they're treating with ketamine, is that going to increase my risk of breast cancer recurrence? And I didn't know that off the top of my head. I've not researched whether ketamine does that. And so I opened the tool, Open Evidence, to make my brain smarter, to say, what is the evidence? Is there any evidence of ketamine in a risk of breast cancer? Which in fact there was not, but it didn't merely answer the question. It gave me resources. I could go to the source documents of peer-reviewed published literature, give it to my patient, send it to my patient, and then inform her of her risk, because it altered my choice architecture. I had more tools at my fingertips. And so I think clinical decision support is the answer, which we do use in clinical practice in how we think about therapy prescribing for patients. At the end of the day, therapy choice is a decision between doctors and patients, but it's informed by having choice architecture really give you choices at your fingertips to make evidence-based choices much easier.
I think there's a couple of things here. Number one, I've been spending a bunch of time looking at e-prior auth, right? So electronic prior authorization, what are the systems? What are the technologies? Is it possible to do it? And I've spent a fair amount of time in clinical decision support as it relates to how you apply CDS tools. Like, how do you get the data out of medical records to feed into CDS tools? Forget the decision support. And I actually think there's kind of two easy spaces where we should all be able to be aligned around these two subjects. Number one, on the e-prior authorization piece, if you look at approvals, if you could speed the process by which something that's obviously should be used, meets the guidelines, et cetera, gets done, and just allow that to be fully driven by AI. So take the denials piece and say, look, when we're denying someone care, all right, or we're doing utilization management, that requires some extra oversight. But if all the flags look green to within some certain threshold, just run it through. That is actually a huge efficiency because right now everything is getting reviewed. So just take that because it's easy. You're not running the risk of doing harm. I want to come back to the option for fraud and waste because there was just a massive fraud case, right, with durable medical equipment companies submitting claims to CMS. It was, I think, over 300 people have now been indicted under that program, and massive fraud related to durable medical equipment and false Medicare fraud. This is the single largest fraud claim or fraud case that's ever been prosecuted. It was announced in June by the DOJ. That came out. So definitely the admission, the approvals are great. That's easy to do. We can do that today. The other thing is on the clinical decision support side, I think if we start fundamentally with the principle of evidence-based medicine, if we think about not telling physicians what to do, but basically saying there is this patient, right? Have they or have they not had the things that should have been done for them, yes or no? And just firing nudges, to your point, Deborah, flags that say, hey, I think this should have been done. Maybe there's good reason why it wasn't, but this test should have been ordered. This thing should have been done. And we don't need to debate, does the AI come up with the right medical decision? Why? Because we can turn to ASCO for what the right, or NCCN for in the oncology space, or the American Heart Association. And then no society is perfect, to the point earlier about, things change over time and we learn new things and there's always new guidelines and else. But at least we have an expert group. So we're actually using the decision support that already exists, but we can integrate it with the underlying infrastructure and systems. That alone should, again, give us a massive amount of efficiency and something that we can all agree on. No one's going to fight with the fact that we should practice medicine to evidence-based medicine standards today. I just think two things. Take the approvals, do them by e-prior auth, take the denials, make sure you hone the model there. And for decision support, let's just make sure that we're giving everybody the care we already decided that they should have gotten. And let's do that because that would lift many, many boats.
Well said. And, I think the nudge theory that Deborah talks about, we have many, many places that are doing that well. At University of Pennsylvania, they've got a gigantic nudge unit. We've done a lot of it here. Deb, you'd be very interested. We found in our review of our lab utilization, we had about 86,000 extra CBCs with differential ordered in our ER over a quarter. And obviously that's a huge cost. And so we looked through things and discovered that in the construction of wrenching in the things for the standardized tools for the ER doctors, some intermediary had pulled in CBC with diff instead of a CBC. And as you guys know, a lot of ER doctors don't need a CBC with diff, right? This is just a baseline lab that you get when you hit the door. And so we didn't take the choice away, but we did put a CBC wrenched in above CBC with diff. And the next quarter, it was 80,000 lower. And so we didn't actually remove the decision making by any single practitioner, but we put the healthy food first. As you've intoned, I think that's the way that we can do this. And that way you include the physicians in the decision making, but you say, hey, listen, were you aware this patient had a DPD deficiency or is a slow CYP3A4 metabolizer of this antidepressant? And those are the things I don't think we can expect every clinician to keep track of all the time, forever, with the tsunami of information coming at us right now. But what if that CDS team, that AI agent or copilot or whatever we want to call it, bumped that to the top of our mind and said, hey, are you aware that your partner, when you were on vacation 2 months ago, sent off DPD testing through your PGX service? And this patient does have a deficiency. So as you're thinking about your dosing, you might want to keep that in mind. Or irinotecan is another example I use all the time because those are buried in the media tab. And I would love to have that media tab front and center every single time with a clinical decision support tool before I write that dose.
Yeah, I feel like it's just going to make us better. And so whether it's chart summarization or chart summarization linked to clinical decision support, or confirming some of the action that you're already having. Doug and I were at the Preciska meeting a few weeks ago, and or with the Preciska leader who has a new AI tool that's clinical decision support around therapy guidance that assimilates a lot of various different guidelines. to support clinical decision making. And listen, I'm not ever going to use that tool to figure out how to treat someone's breast cancer. But if I'm presenting a case in Tumor Board, if there's a case that's controversial, seeing what that tool says can be really helpful and insightful to have a discussion about what's right for the patient, to allow you to really focus your energy on the finer points of care. And that really allows us all to act at top of license, which I think is really important. Again, it gives us much greater reach to provide the best Ferrari of innovative medical care to our patients, as opposed to the speed bumps that we have along the way in looking up if ketamine is associated with breast cancer risk, in the waiting time of prior authorization to get a PET scan to get therapy approved. We want that Ferrari to be on a superhighway. And so we have to be better about removing the speed bumps. So I feel like adoption of some of these tools is really creating that super highway for the Ferraris that we have before us.
I'll give you, to stick with your Ferrari example, one kind of a pivot in the conversation, and that's, you want to give that kind of Ferrari care. One thing that AI brought us is also the ability to find shortcuts, or even find like those back roads that we didn't even know was a quicker way to get from X to Y, right? Like, I mean, I'm talking, we just never knew. And all of a sudden it's like, wow, this is so much shorter. And it goes to this concept of, the mind does not know what the eyes haven't seen. And I think for what we just spoke on, they all help to ensure that our mind knows what our eyes have already seen. So that's the stuff that we know is the way to do it. So in Doug's example, for people that don't know, we had transfusion goals. We're like, yeah, I think we should be about 12 or 10 or above that. And then, so we just did it. We just did it. We're not thinking about the adaptation that can happen, physiologically in the body, blah, blah, blah. And then you started having problems because the blood was too thick, for lack of a better term, in the sense of stroke or heart attacks or overloading certain systems. And we're like, whoa, okay, let's back up. Let's do it less. So that's something that we learn over time. Where I get very interested is the concept of how AI, and I guess particularly foundation models, can really accelerate the timeline of knowing what the eyes haven't seen, and potentially the same way that Google Maps is pretty darn accurate on telling us when we're going to arrive at our destination without actually having to see it or know or have a crystal ball. That's what foundation models can offer us. So in the same way that, the AI might be used for, I said, arthroscopies, apparently, and I'm not an orthopedist, but apparently there's some debate about the utility of arthroscopies in some settings, like for acute settings for sure. But in others, they're like, I don't know if the benefit's as big. It's dropped off by like 46% of some interval in Denmark. And so it's like, I don't know if it works out. I was just telling someone that I heard the same thing about open houses. I don't know if that's true, but that open houses don't actually affect sales of your home. So the point is, we do these things that we're taught. What can foundation models offer us? And then at what point do we kind of relinquish as a scientific community on a foundation model telling us, this thing will not benefit this patient based on all the evidence we have, and when we can really kind of, crunch down all these parameters and variables, or this will benefit it. There's going to be this intersection where it's not necessarily what we have seen, but what something with high investigative capability when it comes to pattern recognition and predictability can actually make us have a potential departure like that back road and get us to our destination more successfully and quicker. And I just wonder, I stay up at night sometimes wondering how we're going to actually meet that. And is it a binary kind of, okay, yes, we're okay with it? What do y'all think?
I think of it as, like Mika said, with prior authorization, if the path is clear and forward, and that's the path you're taking, then pass on. Let your Ferrari enter, of the superhighway. If it is not clear and you have discordance, you have to justify your actions. It has to be defensible. And I would say that's how we use clinical decision support in my practice. So in Texas Oncology and US Oncology, we have evidence-based pathways built within the health record for therapy for patients. And, if you're giving evidence-based choices and that's clear from the information that you have, go, give your therapy. And if you are giving something that is not within that evidence base, you have to justify what you're doing with a peer review. You have to give evidence and have or give a reason for it. Maybe you don't want to give Taxol to the concert pianist that has diabetes and already a little peripheral neuropathy, but you have to justify what you're doing to make it clear why it is, because you have to be accountable for what you do, in the service of patients. So I think actually Mika said it perfectly, and the prior auth argument is very similar to the clinical decision support argument. If it's a clear path and you're on the right road, it's very straightforward. Please go ahead. And if it's not clear, then you have to offer more explanation and justify your actions.
Sanjay, you're talking about foundation models. I keep thinking back to this paper that Epic published right at their user group meeting, where they pushed out around the data they have for Cosmos. So they trained a foundation model on like 350 million. I might get the numbers a little wrong here. Real world data records. And it's the first time now that we're seeing that level of data actually be used to inform models. And, I think it was a good paper. I think there's some really interesting beginnings in that paper, right? Which just makes me even more excited about where does this take us. So one of the things that I've been scratching my head about is like, how do we get hands on, 300 million, let's call it, de-identified representative medical records of individuals and actually train them up? Because if you really wanted to take this like all the way to where it should go, you would want to inform that model, and you'd want it to work at that scale, because, one of the things we thought a lot about just internally as a team, like take names. If you pseudonymize records and you change the ethnicity, right, or gender of the names, and you don't do them right, it actually, it's like this weird thing about like, if you're going to pick fake names, they better sound like Asian names or Hispanic name. Like otherwise the models stop working. And so this stuff is super complex.
And Emily Ray at UNC, I just have to add a perfect anecdote, gave a great example of this, and an article that she did on the NEGM AI podcasts, where she was talking about a model that changed the ethnicity of a child with pharyngitis, and it changed the diagnosis from streptococcal to gonorrheal pharyngitis, just based on the ethnicity, because the models do have inherent bias to them. And so it was a great call out of your exact point, Mika.
Yeah. So if we want to do this, we're going to have to find a way to get the training data that we need. And I don't have an answer for this. It just feels like to me that if we really want to leverage this entire tool set and get out there, we're going to have to find a way to be able to really present the comprehensive training data. I think of this as a little bit like, we know what happens to cancer patients in clinical trials. Why? Because they're in clinical trials and we're testing new things on them. We don't have a really good understanding what happens in general to all the other 95% of cancer patients who go on. We do inside pockets, but I think individual institutions have a pretty good idea of what they did or didn't do and did it or didn't work. But no one can look cross. There's no general centralized learning system or data exchange. And those experiments, people have tried this real world data thing for a long time. I've been working on it for over 15 years. I've never seen a good solution to date that you could actually go in and make a clear, meaningful decision on, or that would adapt, right? So when we try something new and we introduce, let's say, a new practice into the field, is it really working or not? And is it really working for everybody the way we thought it would do? And it all just falls into this murkiness of healthcare data again. I think we've got to figure out a way to solve this problem. Otherwise, we're going to be stymied for some time to come.
The only thing I will add that I think is the advantage of these longer form content shows is that the original construct of us saying we have to solve the problem suggests that there's a single answer. And this is hard, right? This is something where, I just go back to your prior auth example. We all recognize that doctors should have the freedom and agency to make the best decisions for their patients, because the insurance company can't know that she's a concert pianist or that he's an electrician. But we also need them to say, don't transfuse blood needlessly and don't do MRIs for back stuff. And so I think that leads into where I'm hoping that we see this move into polarity management for those of us that read this stuff. Because I'm not sure there's a right answer there. I think we have to balance innovation and safety. We have to balance rapid growth with stability, and things like clinical decision support and prior auth, it's probably going to be both and not either or. I'm not sure I know that there's a right answer to these things, because the tension that it creates is what keeps it in balance anyway. If there are two correct answers, we need to modify our treatment regimens to be cost-effective, efficient, and evidence-based. But we also want to leave the nuance to the physician, that old Atul Gawande tasting the food at the end of the Cheesecake Factory line. I think probably the critical thinkers who are going to start to listen to this podcast month after month and start to see the conversations we're having, it's really a deep problem. And if it was easy to solve, it would have already been solved.
So I'd like to pivot us for a minute. We've been talking a lot about the trees, the real specifics of where it's used and where it's not, and that's so important. I'd like to just take a step back for a minute and look at the forest, because I think that the real where the ball is trying to think about how we use these tools to disrupt healthcare in the future for the future that we have planned. And I think sort of going back to where we started at the health conference, the disruptors in medical care, Mark Cuban disrupting the pharmacy space, Dr. Oz disrupting how we think about prevention. How do we plan for healthcare for tomorrow, right? Because the healthcare that we have tomorrow, right, is an age distribution change of people that have a lot of medical needs, with a medical workforce of doctors, nurses, and other people that are ill-equipped to manage them, given the singular persons that we are, right? And we need these tools for greater reach because we have to do more. We have to depend upon systems that are going to give us greater reach to reimagine the healthcare for tomorrow, to reimagine that people instead of in hospitals can be at home, to reimagine that cellular therapies can be delivered as an outpatient with monitoring, which is about a third of the cost, by the way, than in the hospital setting. To reimagine that people can prevent their own healthcare by being empowered with tools that they get at home, as opposed to having to have so many complex machinations to get it. And so, just sort of repivoting to the health conference, I will say I think it's important to see where the ball is going and to say that these tools are going to be really important in supporting the future that we envision. And it's really critical today that we take the steps that are necessary for us to evolve as organizations and for policies to evolve with the carrots and then later the sticks to get us where we need to be to support this dynamic environment that's changing.
Yeah, I mean, one example I give, I don't think I've ever shared this story, but the way I met Mika was actually to a similar concept. So I'll have patients like, plenty that were sadly like in their 30s or early 40s and stage 4. And so I'd like say I have a colorectal patient that progressed on FOLFOX and FOLFIRI. And I'm like, look, there has to be features about this tumor that somehow have a combination that would give me better than what my third or fourth line option is. And so what X-Years used to do, I don't do this anymore, actually it's evolved quite a bit, but was they would take the different elements of the clinical scenario, and this, a certain percentage, I think more than most, are Medicaid patients. And it was, let's take the elements that are there. Let's look and scrape at every bit of, data that we can find on what ended up happening to patients, the case reports, et cetera, et cetera. And then justified with these kind of literature pieces, the justification to try this. And I never failed once on asking for either an authorization or doing the extended access trials. And this is years ago, mind you. But that's what is the conceivable. It's like based on, it allowed me to take the tragedy that has already happened in the world and actually make use of it so that I can have a better informed decision, for her, him, whoever, an individual. And that's what's possible. What stresses me out, to Mika's point, is, one, getting the data to even have the right representation of certain islands or places that we literally are just so far away from even having the ability to take the DICOM image or whatever that case may be. But then my flip side is even scarier, is how long a community or a region could be starved to benefit from these things as we learn them because of not having the infrastructure. And there is no quick solution to that. It is costly. It takes very expensive and knowledgeable IT teams. It takes bandwidth. What happens in these scenarios? Like, that's my question. Like, do they just literally have inferior care for some duration until someone comes in and says, we'll fund this to be able to now be able to speak through this kind of connection or fire or whatever is necessary to have all the different multimodal elements to have these insights and execute? That's to me, this becomes a moral or humanity kind of question that no one that I know has even a suggestion of how to ensure it doesn't happen, because that kind of disparity is just sickening.
It's going to need principled leadership. It's going to take this 2.5% of early adopters that you're talking to, right? The people that we are bumping into that feel similarly are just as aggrieved as you are, right? For this audience, you may not know, many of you do. I'm a cancer patient myself, my family, many of your families are being touched by cancer. We've been on this call 56 minutes. There have been 230 people diagnosed with cancer since we started the webinar, right? So if that doesn't create that burning platform for change to say, I refuse to have more than half of my patients with lung cancer be diagnosed in stage 4. I'm going to do everything in my power to get lung cancer screening to the levels that we have breast and colon, period. End of sentence. And I think that there are enough of us out there banging that drum again and again that now that middle third that might be the 4th generation settlers, Debra, if we're 2nd and 3rd, because we're still out there pretty early as doctors, maybe they move into the fold and they understand that the mission should be driving these discussions, not the pharmacoeconomics, not the social economics. The fact that there are 19,000 cancer doctors out there feeling as aggrieved as you are, probably all 19,000 are tuning in right now to this podcast because you're that good, Sanjay. I just think it's critical that we start to light that fire and say again and again that we refuse to accept the other alternative, which is to not improve, not embrace, not innovate. And I'm not having that. As a cancer patient, I can tell you I am terribly impatient for you guys to fix this shit.
So, this whole issue of like, how do you really scale, Doug, I think you're right. There's no simple answer here. Right. I think one of the things we struggle with is anytime someone wants to try something new, then we start running into all of this like regulatory stuff. We don't have good mechanisms for trying new things. I always think about like, how could we be more Bayesian, right, in terms of our approach of trying things? Like if I do something different and it works and I can see that it works, wouldn't I want to try it again? Right. But we have a tendency to require these like really high levels of proof essentially before we do anything. And that means the base level investment to do something new often means, and this example you're talking about, Sanjay, it was so new and it was going to cost so much money to get that over the line that you couldn't do it. Like you could not build a business around trying something new. So that to me is an area that really needs to be solved for innovation in healthcare. And to really drive innovation is how can we create safe spaces in which people can innovate? The other concept that I think is really, and I think you're maybe kind of going in this direction with the tension of it, is the idea of coordination. So when you coordinate exploration, so if you and I are like walking out in a field, right, we want to explore the field and we both kind of wander around randomly and we walk in 2 different directions, right, we're both going to know whatever happened in the direction we walked in. But if we communicate with each other and actually pass that information back and forth in real time, we can actually learn from each other's mistakes. And that coordination increases the power of the collective. And we haven't come up again with a good mechanism for coordinating learning, right, across the system that isn't go publish it in a medical journal, right, put it on medRxiv, right, and then hope that somebody reads it one day along with the other 500,000 publications that came out in this year. And so I'm really excited about organizations like, for instance, some of what I understand about Tensor Black of like actually bringing this stuff that people are learning to the forefront, right, and just sharing that information quickly, because that's going to help enable people to actually get this innovation going. I think there will be disparities, Sanjay, to your point. I think it's hard to fight that because there's going to be those people who adopt and there are those, in any circus surfer are going to have to lag. But the only way to fix that problem is to generate the proof so that it becomes a moral obligation, right, to bring essentially the laggards forward.
I think I'm really excited about my Tensor Black colleagues and sharing information because I've talked about for years that I feel like we're on this road to nirvana being like this perfect ideal state of healthcare delivery. And we think about these different tools that we want to use to get us there, no delays in prior authorization, no delays in getting patients imaging, like managing systems optimally, clinical decision support, chart summarization, clinical trial access, like all of the, things that we want to do to make us better. But I will tell you, Mika, what I've learned over time in being part of an amazing big practice filled with really responsible, thoughtful leaders dedicated to the mission is that even with the best tools and really well-intended people, implementation and change management, it is really tough. It is just really, really a tough hurdle for healthcare organizations, or really for any organization, because this is us working differently, and that's really hard across organizations to get people to work differently. And so, I would say counsel that I would offer from the really bruises, scars, wounds of experience is that even with the best of potential opportunities and ways in which you can change your care delivery, that the implementation and change management is really critical. I think the implementation scientists of the world and leaders that have expertise in change management will have great employment opportunities for healthcare for the next decade, as we all are sort of on a continuous process of transformation, because that is really quite a heavy lift.
Indeed, and it's something that we're just all a part of currently. So I'm going to rewind. I'm going to take this beautiful forest macroscopic picture and kind of rewind it back into kind of the more basic, I'd say basic sciences, not necessarily, but at least on how ultimately treatments get better. And that's relating to AI and drug development. And I'll tell you one cohort that's benefiting is animals. So the FDA has this kind of big push to not have as much animal testing, not only for the compassionate part about animals, but also just as with how long and how expensive it could be. And one of the things that people are starting to use are what are called NAMs, or otherwise new approach methodologies. And these NAMs are computer-based modeling and machine learning, as well as human-based models that are like organs on chips that predict how long a drug may work in the body, for example. They're actually being looked at for potentially monoclonal antibodies. And I think I read something yesterday that was showing us how, like, just even the number of errors when it comes to the possible permutations that an antibody or a protein may adapt in the setting of a certain treatment can go down so much, like the ones that actually wouldn't be biologically active because of AI. So I get pretty excited, and I think it's hard for any of us to truly appreciate the acceleration that's about to unfold, no pun intended, proteins, if you're a nerd, with the many different parts and pieces of, from bench to bedside, as they call it, that are going to be accelerated. We can talk about clinical trials all day. When you give the example, Mika, of you want one piece of literature in 5,000, how do you get it to the right setting? Clinical trials, that's the kind of concept behind it. How do you make sure that you surface kind of that more concentrated percentage, rather than just kind of going through the entire Bible of patients and catalogs and disease types? But even earlier than that, what are some of the things that you've seen or gotten excited about when it comes to the discovery process and the availability of tools in our toolbox because of the many different places that AI can help the delay and the cost?
I love mice, and I hate that we hurt them. My wife or my daughter works in a mouse lab. Well, I'm all for this stuff. I just feel like it's so sad. I did it when I was an undergrad. I spoke on this yesterday, and there's a determination here: drug discovery versus drug development. Drug discovery is already changed, right? AlphaFold, Nobel Prize in October, the game changed. And 200 million proteins, we can now identify, because of AI, the rules that they play by. We didn't have to learn the structures, we learned the rules. And so that is now open source, 190 million downloads so far. And so I think the finding a compound that makes sense, that's already being done. The development part is regulated, so that's harder. How do we speed up clinical trials? Can we use NAMs? Can we use digital twins to save us half of the patients that we need enrolled on every trial? Can we ask better questions analyze them more statistically. Again, the tip of the spear here, you're talking about people at large organizations like Texas Oncology, some of the larger groups that are now entertaining these ideas. It should be a mandate. We should be building these tools in and collecting all the data that we can to see which tools work best prospectively. And I'm excited to see that's happening. I will say the disadvantage for all of this is that many of the people leading that have been fantastic stalwarts of good science, ivory tower friends of ours that we all love and respect, AI is new to them too. And so there are no people with 25 years of experience in designing clinical trials with AI. And so the best of them are learning fast. And thank goodness for the AI task force and for JCO Informatics and for our journal that they're publishing peer-reviewed stuff that people can trust. But man, it can't come fast enough for me or the mice.
So there's some concepts that have been around for a long time right here that are finally like moving forward. So, I started my career in computational chemistry, proteomics, and genomics software tools for things like docking and protein folding and tools for X-ray crystallography, right? And I used to sell hard metal servers produced by Silicon Graphics was the company that made those. And, you had 16 processors and you had to have a cooling station built into the room at the pharma company just to buy the hardware to run the processors. And you'd start code and there was no error message. You just had to wait till that thing output like 3 days later. And if 3 days later there was no answer, you had to worry if you turned it off and hit Control-Alt-Delete, was it just 2 seconds away from being complete? You'd have to run the whole thing again.
Oh my God.
Like, that world is no longer here. Thank goodness. I had a lot of fun doing it at the time. But when you take that, and I think, Doug, you made the point of like to development, right? There are tools in development that I think have been there for a while that AI is going to really bring forward. And one toolkit that I think about a lot and have thought about a lot is adaptive clinical trials. Like adaptive trials as statistical methods have been around for a long, long time. There's a couple of great examples in oncology. iSpy, right, is a pretty good example of a pretty adaptive trial that actually worked. And by the way, I don't think I'm saying anything negative here. If you went back and looked at that trial design, you can think of lots of things you might do differently or do better, right? And I think about, are we finally at the stage where if we think about AI correctly and truly adaptive models, can we get to the point where we really take this continuous learning, meaning like we're taking a Bayesian approach, we're expecting some signal, we start to build a basic signal, and instead of having this very stochastic, set piece, staged approach, we're able to manage the predictive model essentially. So you're building a continuously predictive model about how to implement and use something. I think we have all the tools for that. I'm not sure that we have regulators yet or institutions that know how to do that. But the promise there for being able to move very quickly, right, and manage the risks of having downstream impact. Like, again, I think, Debra, you said this earlier, we have all the tools, but actually doing it and implementing that and getting people to understand what it means is, I think, a big challenge.
This is, I think, the task ahead of us, not, and had you asked me 5 years ago, I thought the hard task was figuring out which tools to use and in what sequence and how you prioritize them. And that's not trivial work, understanding who you're going to work with and what you're going to do and prioritizing it and recognizing that you can't do everything at once. But that is not the hard work. The hard work is implementing and change. It's going to make or break us. We are going to see organizations fail in the next 5 years because they have failed to adopt well. We've already seen it. You can think about looking back at transitions of electronic health records that cost organizations hundreds of millions of dollars and, caused failures and layoffs. And, we are in an ecosystem where the future is changing. We have to evolve or we will die.
100%. And, it just makes me wonder, like, if to adapt to that inevitability to some degree of whether they don't want to adopt or can't, if there's like an actual, physical, technical barrier, monetary barrier to not be able to have the tech support to be able to take these things, do we start seeing a little bit of a shift to a healthcare that comes from the individual? So is there an entire ownership of like a mobile chart and information, kind of information prepared individual that can now use this almost universal remote to go get and seek the care that they need given or despite the limitations that may be done locally. And then I think about, okay, what would have to evolve? And this goes back to Bertalan's episode, Doug, and Mika, Debra, I don't know if you've listened to it, but think about what has to happen in the landscape that is today. And if that's the case, now you're talking about insurance that just changes or adapts to this, potential of the individual going to different places. But at the end of the day, if that makes their lives better, less debility, less debt, less admissions, you could see how that's a quicker acceleration to say, hey, go where you need to go. So I just wonder, is that one of the potential solutions of rather completely, breaking down or building back up or swapping in the hardware, so to speak, of a facility or a region? Do you get into this more mobilized, mobile? I mean, that's the word, mobile healthcare system that the patient goes to access? I don't know.
Yeah, I think you do, Sanjay, and I think that our the next generation of healthcare leaders, that they're digital natives, and this is going to come very naturally to them. Sanjay, I would say you're on the border of a digital native. Doug and I are older than you are, so we've had to try to learn it and become travelers in this space. But our children, Doug and I both have medical and pre-medical students as children. This is just how they work, right? This comes very naturally to them. And they will have expectations of doing it differently. I think a real challenge that people don't talk about is, there's industries that are really quick to disrupt in tech, where you have a bunch of 20-year-olds working. But, I wasn't an oncologist until I was like 30, right? Because it takes a long time, like 27 years of education to get here, that there's going to be a delay in adoption in healthcare, just merely by the nature of the fact that the people that are leading change are older, and there's fewer of us that are apt to change.
I see that here. And I love the place where I work. It's a super, super forward-leaning hospital system, great leadership, consistently kind and good. But you're right, the people making the decisions, once you get to a senior vice president level, and you can write checks for products, or you're the CEO or COO level, you have different responsibilities and a different level of risk tolerance than I did when I was 30. And so the job descriptions are also different. It's don't break the store. And that's that polarity stuff. They have to invest and innovate, but they have that proverbial one foot is on the dock, the other one's in the canoe, because you also can't make a mistake with a patient's life. And so I think that's where the clinicians should lead, because we have evidence-based solutions. We have peer-reviewed journals. We have good science. We have tools that we can test using good scientific method and say, listen, the benefit outweighs the risk here, just like it does with that Taxol, just like that does in that immunotherapy, where there are risks and benefits. But our job is molecular chemists and artisans is to say, in my belief, with my foundation of knowledge, which is now growing briskly with AI, I believe that the risk outweighs the benefit outweighs the risk here, and we need to do this. And if you want to do it in a trial, great. That's called a pilot in business. Do it for 6 months. Fire bullets before
and I think we all have to own. And Doug, that example of the oncologist and chemotherapy is a perfect one. We all have to own that we are going to do some really expensive things that sometimes fail. Just like when I give, trastuzumab deruxtecan and it doesn't work. It actually usually does work because it's a very effective therapy. But I give a lot of expensive therapies that sometimes don't work. And I enter into it knowing that, right? I'm going to make a choice to do this expensive thing, hoping that it's going to work well. Sometimes that works out, sometimes it doesn't. But to quickly go back with honesty and transparency and say, okay, this is working or it's not. If we need to pivot what we're doing, let's make a pivot. Let's do what makes sense next to try to help us get where we need to go. And I think as oncologists, that comes super natural to us, because we do that every day.
Yes, we expect failure. Now, I want to use just the last couple of minutes. To some degree, it's tolerated failure.
Because it's such a nihilist for his age, isn't he? See, I'm hopeful and I'm old.
Well, we would have been surgeons otherwise, right? No. But what we did promise, and to the sentiment of tools you may or may not know to use or how to use them, we promised some personal tips that could help your personal life. I'll tell you a couple of updates. that I'm excited about. ChatGPT now, it has the ability to have apps inside the actual ChatGPT. So if you want to hook up your Spotify, etc., it can now communicate with them. I think this is just the beginning of what's going to change so much. I was telling my EA, I was like, and I guess she wasn't as excited. I was like, I can ask, by connecting to ChatGPT, you can connect your email. Of course, privacy is something you want to think about and what the nature of the emails. But now you can say, hey, what was that email from that so-and-so person? Can you bring that up? What I just asked it, what travel do I have left in through December? And ChatGPT just made this beautiful agenda with every flight and every city and what the title of my talks are. So we're talking about tools that are very equitable, to most to be able to do. And on top of that, so if you're not familiar with N8N or these kind of automation, builders. Now, ChatGPT, it is not automation, but it is agents, has made it so simple. I'm sure Mika's kind of like, why did I learn all this other stuff, when it came to the techie stuff, to just be able to start creating your own agents. So when we talk about, knowing and having a familiarity with these kind of tools and ways that can really ameliorate our lives, these are some of the things that I personally get excited about. I don't know if y'all have any. I've requested VO2. If you haven't Googled VEO space 2, it's the new video capabilities of ChatGPT, and it is insane. I've seen some pretty, things relating to Stephen Hawking going down like this slide as if he's doing BMX, and they have Tupac and Biggie talking, and it is unbelievably indistinguishable from what you would think is real film, which I think is going to, tie into education one day and getting to prompt. Google has this way of saying, teach me, I forgot what they call it, but they say, teach me the way I learn. So if you are a basketball athlete and you have a 5th grade level and you need to learn about some complicated physics subject, instead of being stuck at the textbook level, it will do only basketball analogies or messy, analogies with soccer and physics. So we're talking about having very malleable ways of absorbing learning and education, with also the ability to invent the most creative things with VO2 and other video modalities. So these are things that I would recommend that y'all play with. And I don't know if y'all have any that you like or want to share or excited about that came out recently.
We need a whole episode on the tools, because I'm jumping between 5 or 6 a day now. And every time I see an output, I'm like, my life can never be the same again after one output. And I
love you people, but even just your text messages over the weekend to keep up with them, like I'm behind. I gotta catch up.
Yeah, I mean, I'm telling you, I had Perplexity and ChatGPT, the Asian modes on both, compete about trying every single coupon code at a furniture place, because we have to replace the furniture in our bedroom. And it just tried all of them. And it just tells you, it's like, oops, my bad, I'm back. My cart's empty. I need to restart. So they're not perfect, but it realized that somehow I'm on a baby registry. Let me go back. That's what ChatGPT had said. But the fact that you can just tell it to do something and then go and make tea and play with your kids and come back and it's done is just insane,
Look, I do a lot of work around contracts, contracting, financial metrics, right? And if I go back even like a year or two and asking, some of the AI for like financial projections or market analysis, some sort, it wasn't real good. It was just bad. Honestly, you looked at it and you're like, I got to just do this myself by hand. And now it's fantastic, right? The type of, providing a few examples. I don't know whether the models have much better trading data or they've had more exposure to different business solutions or not, but they're, instead of being 80% out of the gate, it's now at like 95%. So there's still 5% you got to tune up, but like most of it's just there. And the biggest thing I have to remind myself is you still got to go back and read it all, because otherwise you end up with something you're like, oh, I got so used to skimming it. And I was talking to actually a guy from UCSF, Dr. Ben Rosner, who's an ex-colleague of mine and friend. And he was talking about the untraining impact, right? So he was talking about people who used AI for colonoscopies, right? And the doctors who use AI for colonoscopies actually have poorer results for colonoscopies without AI after using AI than they did before, as they literally untrained themselves by using AI. So I hope we're not untraining our minds from everything here.
Well, it's like knowing north, south, east, and west. I mean, that's truly not a thing for people. And it's like we're talking hundreds of years. That was just so conceptually necessary. So there is certainly this concept of dependence or untraining, in this capacity that is very real.
Sanjay, do you know your wife's phone number?
I do.
Can you name 4 other phone numbers?
No.
I mean, I don't.
No.
We used to know them all.
None.
I don't
If
know
she
any of
never
my
answers the
kids' phone
phone.
numbers.
So
And
like, yeah, if I have one call and she's not going to answer it, that's all I had. So I've wasted my one call because I know she won't answer. Well, thank you all so much. This was awesome. I would love to know. We'd all love to know anything that the listeners would like to hear about, to learn about. Do we talk more about policy, less, more about workflows, and it's just so exciting and truly a 360 degrees when it comes to AI and healthcare. So until next time, we'll see you soon.
Thanks, Sanjay.